Ken Moriyama. I'm the chair of the Resident Education Committee for the SSAT, and this is actually the first fellowship fair. This is an idea that was brought together by the Resident Education Committee. We're very fortunate that the organization has been very supportive of us doing this, and we're also fortunate to have representatives from 5 major surgery organizations that sponsor fellowships. And the idea here is to give residents and students who are interested potentially in careers some idea of what it's going to involve to be in a fellowship, what it takes to apply to the fellowship, how to prepare for that process. We're also lucky Dr. Fabrizio Michelazzi here, who is the president-elect, soon-to-be president, is here with us today for this inaugural fellowship fair, so we're very appreciative to have you here. I do want to thank the committee members, some of whom are here, Brian Davis, Jaylene Grams, Amin Madani, who really did a lot of work to put this together. And I'm going to turn this over to Jaylene Grams, and she's going to do the introductions along with Amin. And then at the end of it, we'll have a lot of time for questions and answers. And we encourage you to participate, ask questions after the presentations are complete. This is your opportunity to learn about what it's going to take if you're interested in applying to a fellowship. And each speaker will have about 5 to 10 minutes. So it'll be relatively informal, but if we can hold the questions to the end, I think we'll really have a lot of opportunity. There should also be time for you to interact one-on-one if you have specific questions that you would like to ask them in private. So without further ado, Jaylene.
Thanks, Ken. Again, I would like to welcome everyone here and thank you for coming to the first fellowship fair. I'm also a scientist, and so I'm kind of a show me the data kind of person. So I put together some slides to kind of tell you some basic statistics about fellowships.
So when you're thinking about fellowships, you can go through the Fellowship Council, which handles the non-ACGME accredited fellowships, and the NRMP, which handles the ACGME accredited fellowships. I never really understood that. There are some fellowships that have both ACGME and non-ACGME accredited fellowships, like thoracic surgery, colorectal surgery, and there are some programs that only exist as non-ACGME accredited fellowships, like the Advanced GI, MIS, Bariatric, and Flexible Endoscopy, or any combination of those type fellowships.
So these are some statistics on the Fellowship Council matches. So they include the Advanced GI, MIS, Bariatric, Flex Endo. There are about 125 programs. We couldn't specifically nail down how many positions there are nationally. And then of their HPB fellowships, non-accredited fellowships, they have HPB, HPB Transplant, HPB Surgical Oncology. That's about 27 programs nationwide. And again, we couldn't really get how many positions there are. When you look at program fill rate for these, there's about a 91% program fill rate, and about 64% of the applicants matched. Now, those last two statistics do include non-accredited thoracic and colorectal surgery programs. I kind of lumped everyone together. So if we graph this data out, they published this, and it's all on their website, and you can get it back from 2003 match years. You can see that the number of applicants has been increasing over time. The number of positions has also increased over time. Program fill rate looks like it's about the same, and applicants matched goes down a little bit. I expanded that area of the graph to show you that fellowship program fill rate is pretty good, and then the match rate is actually decreased over the past 10 years from about 74% to about 62% now for the Fellowship Council fellowships. If you look at the applicants, number of applicants per position, we saw that the applicants is increasing and the number of positions is increasing. Number of applicants is increasing at a slightly higher rate than the number of positions, so that the number of applicants per position has also increased to about almost 1.5, so 1.4 some applicants versus closer to 1.1 10 years ago. If we look at colorectal surgery fellowships and surgical oncology fellowships, again, this is through the NRMP, you can see that about 74, that's a number, 74 out of 128 applicants matched into colorectal surgery into the 2014 appointments. That's an overall match rate of about 72%. And if you look at U.S. grads matched over U.S. grads applied, it's about 83%. If we look at surgical oncology, 37 out of 103 people matched, so that's an overall match rate of about 54%, so one of the more competitive fellowships. And then again, for colorectal surgery, they had this data to look at the number of applicants, positions, program fill, and applicants matched. And for colorectal surgery, everything has kind of stayed the same. So if you look at the number of applicants per position, again, it's stable at about 1.5. And then if we look at colorectal surgery and surgical oncology, they had this data online, how many of the applicants got their first choice, their second choice, or their third choice. And you can see that about 31% of people got their first choice in colorectal surgery, almost 10% in their second choice, and about 10% their third choice. And then for surgical oncology, you can see similar numbers, where about 50% or a little less of people are getting a match in their first top 3. Okay, so that's just kind of some statistics to get you guys thinking about questions you might want to ask the panelists in terms of, potential match rates, how do you get the fellowship you want, things like that. And then Amin Madani is going to say a few words. He's a PGY 3 fellow at McGill University, and he's a resident representative on the SSAT Resident Education Committee.
Thanks, Jaylene, for that nice overview. So this is really exciting. Thanks for coming today, and the first of many, hopefully, fellowship fairs for GI fellowships. Just maybe we'll start off with just a show of hands. How many residents are there here today? Okay, good. And maybe keep your hand up if you plan on doing a fellowship eventually. Okay, so everybody here is interested. So as Dr. Murayama pointed out, so what we've done with this session is we've broken it down into the different fellowships that are available, and we've invited speakers from the major surgical societies to who represent each of those fellowships to come give us a broad overview of what it's like to pursue a career in each of those fellowships. And really, this session is designed for you. It's really resident-centered. Ask a lot of questions. This is your chance, because I think as a resident, it can be pretty daunting at times when there are a lot of avenues that are available and we're not really sure which to take. We don't always get exposure into every facet of surgery, so it can be pretty daunting, and our decision making is a lot of times subjective. So if you ask yourself these things as to, okay, who do I have to do research with? Who do I need to introduce myself with? Which societies do I have to, which meetings do I have to go to? Who do I network with? So this is really your chance to take full advantage, ask a lot of questions, grill the panelists, and get a better understanding of what's available to you. So that's kind of from the residents' perspective. So that being said, we'll start with our first speaker. We'll start with the hepatopancreatic biliary speaker. I'd like to introduce Dr. Rohan Jayaraja. He's an attending staff at the Methodist Hospital in Dallas, and he's also the director of a surgical oncology program, as well as the Upper GI Fellowship / AHPBA Fellowship there. He also is the chair of programs director at the AHPBA, and he's done his training at the University of Chicago and also did a liver transplant fellowship at Baylor. So let's welcome Dr. Jayaraja. Tell us how it's like to be an AHPBA surgeon.
Let me just make sure you should have a slide set for me. HPB. So while we're getting the slide set up, I'm Rohan Jayaraja, just to give you a little bit of background about me. It's the purple one, yes, that's right. And let me start out with my first apology. I usually like to have my shirt match my slides, but apparently I didn't do a very good job today. I'm also especially nervous because the person who taught me everything I know is Dr. Michelasi, who's here. And so he's my mentor. It's kind of like the Hunger Games. Navigating the process for HPB. So just a couple of quick words. What is HPB? Why has it become a field onto its own? And how does one become an HPB surgeon? As you heard about the hats that I wear, and I was actually kind of freaking out this morning because I was like, am I talking from the AHPBA standpoint or the Fellowship Council standpoint? I'm here for the AHPBA, but I also am chair of accreditation for the Fellowship Council and very involved in both the SSO and the AHPBA, as you can see. HPB surgery. So what is HPB surgery? When I finished my training in the 90s, this field was really non-existent in its own entity. I think these are some of the things that constitute HPB surgery. And the key things for me are that you learn both benign and malignant disease. You need to know about the oncology side of things. you need to be a really good critical care doctor too. I think it bridges the gaps between these professions or these different subspecialties. And my passion has always been to bridge that gap between transplant and surgical oncology, because you really need to think as well as operate. And sometimes that can be a difficult mix. And those of you know that there are some people, liver lesion, it comes out. Well, hold on, it's a hemangioma, right? Do we really need to do that? And so you really want to be able to think through this. It also aggravates the hell out of me when people don't, who operate on the liver don't know what fall fox is, right? So you've got to know the surgical oncology side of things, but you've also got to know the technical, very, aggressive side of things. You want to know the knowledge of oncology disease, benign disease, be aggressive, but also be thoughtful. And as time has gone on, HPB disease is becoming more and more regionalized. And so the truth is, more of these complicated cases are coming to people or surgeons that have spent additional time training in various modalities. I just would say that we really need to have a quorum as to how to do this, and I'll talk to you a little bit about this at the end, because before long, with healthcare reform, if we don't look at ourselves, look at our outcomes, look at our training paradigm, somebody else is going to do this for us. And all we need to do is look around the world to really realize that. One of my mentors once said, before you get to the operating room to do a Whipple with healthcare reform, you may have to have your iPad there and check off the boxes before the operating room door opens. And we need to think about that with regard to training too. So everyone has become organ-focused, as you know, by this panel that's sitting here, colorectal, thoracic, breast. I mean, even within transplant, their kidney programs, their liver programs, and their multi-organ programs. And before 2000, before the Blue Ribbon Group, I'm not sure that everyone felt that you needed to do a fellowship to perform some of these complex HPB operations. But I think the truth is, and you are all telling us this, in the year 2014, really, I think a fellowship is required. This was, when I trained with Dr. Michelasi, we worked an average of about, 110 to 120 hours a week. There was a desire to do everything. I mean, I came out trained wanting to do everything from a colon to a thyroid. And to some degree, I still have a practice that's sort of unusual, because what I didn't tell you is I spent 8 years in academic medicine, and now I'm in more of a private environment. So we have a residency and we have a Hepatobiliary Fellowship, but I have this very unique perspective of understanding what academics is like and also understanding what the private world is like, which is really interesting, because I never realized that, it's kind of like being the department chair of my own little place, because I have to actually know what the internet feed costs me, to bring it to the office. I mean, these are things that nobody really thinks about, but they're important. So with the work hours restrictions, the SCORE curriculum defines really gallbladder and liver biopsy are the only two things you need to know independently. You need to be able to talk about other HPB procedures, but not necessarily be independent doing them. And so you've all told us that you want to do fellowships. And again, with HPB, bridges transplant and SSO, they're housed under the Fellowship Council, and I just want to clarify one thing that was said in the introduction. Remember, these are accredited. They're just not ACGME fellowships. And the accreditation, and I feel so strongly about that because I'm chair of accreditation, so I'm really trying hard to make these really, really strongly accredited, very thoroughly. The process needs to be thorough. What I want you to understand is that the decision to not be ACGME was very specific. And the reason is because the big buzz in fellowship training now is transition to practice. Okay, and so the American Board of Surgery, the American College, all of these big societies are talking to us about how can we make you all regain a little bit of that independent operating that we're missing now from general surgery residency. Through non-ACGME accreditation methods, there is a little bit more flexibility with some of these maneuvers, including placing you as faculty, including fully licensing you, etc. So we really focus on transition to practice. And just so that you know, and you'll hear, we have many different fellowship types that are housed on the Fellowship Council. This is my Fellowship Council hat. And I would encourage you to know that each of these fellowship types have a sponsoring society. So for us, for HPB, it's the AHPBA. For MIS colorectal, it's ASCRS. Thoracic does not have one as yet, but we're working on that. Bariatric, ASBMS, etc. So the guidelines for training within the Fellowship Council fellowships come from the sponsoring societies. We then carry them out through the Fellowship Council. I hope that's clear, and I'm happy to discuss that further because it's an important thing. We have site visits that happen at the start, and then every 3 years is the most time you can get. These site visits are really rigorous, and it's like an RSC site visit. I mean, I can go in there and I go to these big name programs and I'm like, I'm just a little country doc here, guys, but tell me, why is it that your fellow on the HPB rotation goes away for transplant? Okay, that tells me there's some political issues here because you've got a transplant program. So how can you not make this work, Mr. or Ms. Chairman? And I have to ask those questions and help the fellowship be better educationally by helping to fight some of those political battles. It's a really neat, it's the greatest thing I do. It's really fun. HPB, 1 year, benign and malignant, a lot of MIS, ultrasound, ablation, etc. And just so that you know, these are the numbers that we require. Remember, this is just one metric. Pancreas 25, liver 15 hemilivers with a total of 25 liver resections and 15 bile duct cases for a total of 100. So for example, transduodenal ampulectomy would count under a biliary case, for example. So we look at the numbers, but we also have a curriculum, etc. You then apply for their fellow to receive a certificate of training through the sponsoring society, which is the AHPBA, and the ASBMS is actually beginning to do exactly this. So this is really a good thing, I think. And it's presented at our national meeting. The certificate is really sought after, and as you can see, there are some SSO programs that are now asking for dual accreditation in order to get the certificate of training. So this, I think, is a good thing. And some ASTS programs too, some transplant programs. And so these are the list of programs. We have some material, right, Renee, somewhere? We have some materials, so please grab them on the way out. We have these list of fellowships, but these are the fellowships that are HPB programs. As you heard about, some have 2 positions, some have 1. We have a total of 21 HPB fellowship programs, and then an additional, these are more HPB programs. And then we have combined programs, which are here, which are technically not through the Fellowship Council match. So the match is actually through the Fellowship Council. These programs match through the transplant match or the SSO match, but they have dual accreditation through the Fellowship Council. Last thing, promise I'll finish, Ken. Ken was like, oh my God, you got so many slides. Are you going to talk? You're going to be able to talk quickly enough. I try to put just one thought on each slide because otherwise I forget what I'm going to say. So, so I'm working on this consensus conference, and this is really exciting, I think. I've managed to get money, usually money talks. So I've got all 3 societies, ASTS, SSO, and AHPBA, to put up funding for a consensus conference on training in HPB surgery. It's going to be on the Monday of ACS 2014, so this year. And my idea here is that we should look at common training guidelines across the different pathways. And we're very excited and would love for you all to come. I personally think we need to hit one of the biggest issues, which is credentialing, because right now when you finish your general surgery training, you're checked off to be able to do everything from a low anterior to a thyroid. And I don't know, I think the time may come when that's not going to be the case, especially since SCORE doesn't really match that. So I'm not quite sure where we stand with that. So again, I'm hoping to have a consensus statement. And so I hope you understand what HPB surgery constitutes, and I hope you want to become one. So thank you all very much indeed.
So Dr. Michael Ujiki is currently a clinical assistant professor at the North Shore Medical Group. He did his MIS fellowship actually with one of the premier programs, highly sought after fellowships in the United States for MIS, with Lee Swanstrom at Legacy Health Systems in Oregon. So we're excited to hear what he's going to have to say to us.
Thank you very much, and thanks, Ken, for putting this together. This is a great idea. When I was a chief resident, or actually more of a fourth-year resident, I trained at Northwestern, and we had what I thought was an excellent training program, and I still do. We had great mentors like Dr. Moriyama, Nat Soper, and Mark Talamonte, and I felt like, I could operate fairly independently. But after a lot of discussion, decided to go and do a fellowship with Dr. Swanstrom. I had done probably around 15 to 20 fundoplications and paraesophageal hernia repairs when I was a resident, and I really felt like I knew how to do it. And then I went to fellowship and I did about 70 more, and I realized that when I was a resident, I had no idea how to do it. And so I was very grateful that I was not only talked into, but made the decision to go forward with the fellowship, and urge you all to consider the same. At the time that I trained, there were really only MIS fellowships, but it's interesting, now things are changing, and as we just heard about, fellowships and surgeons, quite frankly, are becoming more organ specific. So I'm not sure where MIS will fit. I think in many ways, for example, Dr. Swanstrom's program, when I was there were 2 fellows, and we did rotations on colorectal, hepatobiliary, foregut, and bariatrics. And soon after myself and my co-fellow graduated, they changed the program. So now that there's 2 foregut fellows, there are 2 colorectal fellows. As you saw, the legacy group, there's 2 hepatobiliary fellows, and there's 1 or 2 bariatric fellows. So everything is becoming a lot more focused. So when I speak about MIS fellowships, there are obviously still quite a few out there, but I would guess that a lot of those fellowships have some sort of focus. And also there may be a place for a general MIS fellow for someone who may be practicing in an area where there's a need for a general MIS fellow. So something to think about when you're applying as to where you see yourself in the future. If you see yourself in an academic setting, large metropolitan area, you're probably going to need to be a bit more focused on an organ. If you see yourself, if you're from a rural area or a suburban area that you see yourself doing a more general practice, then perhaps a MIS program with more of a general focus is appropriate. Those are things that I would think about. The MIS fellowship is through the Fellowship Council, as we just heard about, which appears to be well headed on the accreditation side, and so that's how you can apply. We actually were fortunate enough to get our fellowship approved. We haven't started it yet, but that's how you would apply. I'm also here to speak about SAGES. SAGES is the Society for American Gastrointestinal and Endoscopic Surgery, and it really is a society for minimally invasive surgeons of the digestive tract, surgeons who do a lot of minimally invasive surgery as well as endoscopy, and we do hit a lot of all the different specialties, whether it be colorectal, HPB, bariatric, and foregut, as well as endoscopy. The mission is to improve quality care through education, research, innovation, and leadership, principally in gastrointestinal endoscopic surgery. And really, this society is heavy on innovation, so new techniques, new procedures, and minimally invasive procedures. Just some facts about the society. It was founded now over 30 years ago, and it's a fairly large membership of over 6,000 people from around the world. There is an annual meeting, and it's one of the more technologically advanced meetings with digital posters and great CME courses for the participants. If you were to join SAGES, you would have opportunities to have videos that you can access, as well as images for presentations, journal access. There are several video textbooks that you can obtain. And actually, even if you're not a member of SAGES, if you go to the website sages.org, you will be able to access a lot of the content. For example, a lot of the videos actually are open to anyone, and I would urge you to look at them. It's a great way to prepare for a minimally invasive case the next day. And really, I think SAGES has been very generous in terms of providing free content. There are other things, humanitarian efforts, and then the endowment for SAGES is fairly large at $10 million. So it's a society that's doing very well and financially very strong. Why I joined SAGES, SAGES again seems to be a lot like an MIS surgeon, which is kind of at the cutting edge of new technology, new techniques, and any society really is there for you to develop your profession, and not just through hearing and learning about new techniques, new technology, but also developing relationships and networking. And that's probably the most important reason why you really should consider joining multiple societies within your specialty, and that is that it's an opportunity to get together with people in your own field, share ideas, even perhaps collaborate on research together. I can't tell you how valuable it is, and it will help you grow, and it will also help the patients that you treat. SAGES is a society that helps support people who've had achievements in their profession, and it obviously exposes you to state-of-the-art surgical technology and techniques. If you are a member of SAGES, there are some grant applications and research awards that you can apply for and obtain. And, SAGES also offers an opportunity for leadership. I'm a member of this membership committee of SAGES, and just we asked people why they joined SAGES, and I just put a few quotes up here. One is, SAGES has been the most meaningful part of my surgical life. I can't imagine what I'd do without it. SAGES is the place that I come in my professional life to get excited, to get energized, and to work on projects that have real meaning and are going to come to fruition and have impact. And it's a place where I meet my friends and make meaningful professional connections. SAGES brought together a group of energetic, bold visionaries who had the guts to do things that hadn't been done before, and with that, they changed the history of the world, and they changed surgery. Very dramatic, but these are just some of the comments. So happy to answer any questions. The website, again, very valuable resource for you. A lot of free content on there. Of course, we would welcome your membership. It's not expensive, $60 a year or so for a candidate member. If you have any questions, I'll look forward to speaking with you all. Thank you.
Next, we have Dr. John Morton. We're very pleased to have him here. He's an associate professor at Stanford University. He's very well published on bariatric surgery, both from more a scientific perspective and a clinical perspective. He's also the president-elect, or the incoming president for the ASBMS.
Well, thank you, and I want to thank Ken for the opportunity, Dr. Michelozzi for this. I think it's a great forum for all you to learn about your future, and I think what's important as you move forward in deciding what you want to do is take a look at the fields. Take a look at where they're at a trajectory. Some of the fields are more established than others, and when that happens, you have a lot of things that are already worked out. One interesting thing about bariatric surgery is we're relatively young. You will be present at the creation, if you will. The history book is still being written when it comes to bariatric surgery. American College of Surgeons is 100 years old. Bariatrics as an accredited field is only about 7. So it gives you a real opportunity to get things started. As you know, bariatric fellowships are fellowship council accredited. And I think there's a few things that I'd like to point out to you today. One is that there's an increased need and utilization and safety for bariatric surgery. If you look at what's the upswing, what's the market like? Is there going to be a job for me later? I think you got good job security in bariatric surgery. Just take a look around downtown Chicago. But what we can see here is we've got 18 million people who qualify for weight loss surgery, and we've had a tremendous increase in the number of procedures we do. We do roughly 200,000 cases a year. 200,000. So it's quite a few. So there's clearly a big need. The other thing that's happened over the last decade has been a big decrease in mortality. And bariatric surgery and quality are very closely intertwined. As surgeons, quality is part of our DNA, but it's been nowhere more common to apply than in bariatric surgery. We were actually forged in adversity. You know, maybe about 10 years ago, and Ken will attest to this, you know, there was a lot of concerns about bariatric surgery, you know, quality-wise. But if you take a look there, our mortality rates now are on par with hip or knee replacement and removal of a gallbladder. And I firmly think that one of the reasons are that we accredit hospitals, but we also have things like this, fellowships, people that get trained, and so when they go out, they hit the ground running and can make a difference. The other thing I want to point out is, as you guys move forward, I remember your personal statement. We read them. You know, you want to help people and you want to do things that make a difference. Well, I think this is a place where we're going to make a difference. If you look at what our biggest problem is in the United States, cutting across board public health issue-wise, it is obesity. And surgeons have often been there first when there's a problem in public health. Well, before we had, you know, all the different antibiotics for TB, TB was a surgical disease. Same thing with heart disease and cancer. So I like to think that, you know, as surgeons, we're there first again when it comes to obesity, and we can make a pretty big difference. The other thing I want to point out to you is you are treating a disease. You know, it's not just one single body part. That's one thing that appeals to me tremendously. You know, if you look at the effect of obesity, it's literally from head to toe. We work very closely and collaboratively with other fields. You know, the orthopedic surgeons send us the patients before they put in a joint. We work with transplant. We work with endocrine. So it's a very exciting field where you get to work with a lot of different folks. You're not just closeted off in one section. A lot of different areas. I'll be honest, the reason I went into bariatrics when I was a fellow, actually my fellowship was an MIS fellowship, and I wanted to do it for one reason. It looked hard to do, and I wanted to challenge myself and see if I could master that technical challenge. And since then, I've realized that the skill set that you acquire in bariatric surgery will serve you well anywhere in the abdomen, you know, whether or not you're doing any sort of other suturing or moving around any sort of other organs. So that has tremendous appeal to you. If you like cutting and sewing, this is a good place to be because we do a lot of that. The other thing, as I mentioned before, a lot of opportunity for growth. We're not done yet, and I think, frankly, the field will accommodate probably 500,000 cases a year. Lastly, the variety that you're going to see is just really tremendous in terms of the types of operations and how we do them. And finally, and I know this sounds corny, but we did get into this for one reason, right? To help people. And if you talk to bariatric surgeons, they got a little gleam in their eye. They get very excited to talk about what they do because if you've ever seen these patients before and after, a year later, it's an incredible treatment effect and you really change these people's lives. It makes a huge difference. The other thing is this isn't cancer, so this is an elective procedure, meaning for me, we have the opportunity to plan everything out. You know, we got the electronic medical record, everything's done, consistently standardized, so it runs like a top. I operate on Mondays and Tuesdays. My length of stay for these cases are 2 days. You can do the math. We don't have everybody in over the weekend. The other thing you can see here is, so this is, I just want to show you, this is from our own center, just to give you a little bit idea of what we do. And some of the programs are combined when it comes to bariatric and MIS. And when you do a lot of bariatrics, you're going to come across patients who need hernias, patients who may have a paraesophageal that you'll want to fix before doing the further procedure in bariatrics. But you can see it's a good variety. The other thing I want to point out, if you want to look at new things coming forward, this is an interesting place. In terms of endoscopy, we use it quite a bit. Every single sleeve we do, we use the endoscope. We use the endoscopic interventions for the balloon. GI Dynamics has got an internal sleeve. All that stuff is coming forward. Vagal blockade for weight loss. So very exciting. Like I said, present at the creation just to start. A few things, you know, around certification, and we have some handouts in the front that Renee has made available, but these are the different components for the fellowship certification that I encourage everyone to do. I want to just point out one last part. Through the direction of our current president, Nin Nguyen, we are looking to apply with American Board of Surgery to have us become an added qualification. So we'll be on par with things like hand surgery and things like that. So it'll be very much a set field with a set area of expertise. I wouldn't be a bariatric surgeon if I didn't have show and tell pictures, okay? And so here's one of our patients. This is a former high school wrestling coach, had 2 open hearts, was on several medicines for his cardiac condition, and he owns his own life insurance company, and there he is. The other thing I want to point out is that when you do this, it has impact literally from family all the way up to genes. Telomeres. Telomeres are a marker of aging. So believe it or not, we did a study taking a look at this and showed that surgery has impact on the aging process. Telomeres are like the ends of chromosomes. When they divide over and over again, they degrade, like those little tips you have at the shoelaces. And what we were able to show in the study was that that these patients ended up losing weight and increasing their telomere length and decreasing the aging process. It's becoming more and more important to us as we move forward. The other thing I want to point out is, as I said, it's from gene to family. You even get secondhand weight loss. You can see that in this study here. Not only the patients lost weight, but so did the family members. And here's that correlation that you can see here with the telomere length and the weight loss. And I'll show you here a couple of patients, husband and wife, operated on them same day, and there you see them with their kids. And here they are about a year later. So the impact you have is above and beyond the operating room. If you want to make a difference in a place where it really matters, bariatric surgery is a great place to be. And you can see that with this study here that we did. So I'll close here by saying that it's so good to see so many people interested in doing further training. And obviously I care a lot about what we do. When you look at the field to go into, look at the people in it and say, are those people like me? And you'll find a welcome to your new surgical home. So thank you very much for the opportunity.
So our next speaker will be representing colorectal surgery, Dr. Liliana Bordeanu. She's an attending staff at Mass General Hospital in Boston, and she's also an assistant professor at Harvard Medical School. She's the co-founder and co-director of the Pelvic Disorder Services Center at Mass General, and she's also done her training not only at Harvard, but also at the University of Minnesota. So Dr. Bordeanu, can you tell us why we should do colorectal surgery?
I get this question a lot of times when I examine my patients. Why the hell did you choose to be a colorectal surgeon? So depending on my mood, I say things like, well, I was the last one to be chosen, or I always liked the idea of being a kick-ass surgeon, But sometimes it's not the appropriate answer, so then I just mumble. But the honest truth is that the choice at that particular point in time was very easy. You heard a little bit about accredited, non-accredited fellowships. When I was choosing a fellowship, the choice was Surg-Onc, MIS, and colorectal. Those were really the only fellowships out there. Everybody else otherwise sort of subspecialized slowly over time, but they didn't necessarily go through a fellowship track. And the only fellowship that was actually board certified, where you actually had to take an exam and put a diploma on the wall, was colorectal surgery. And so that sort of piqued my interest, because we did not have a colorectal fellowship at Mass General where I was training. So I started finding out, why the hell would somebody need to do a colorectal fellowship? What does a colorectal surgeon do? And so let's see if I can go back. What I figured out is that essentially a colorectal surgeon operates on everything that's below the ligament of Treitz. Small bowel, which is Crohn's disease usually, and that requires understanding of the medical therapy of the disease, close collaboration with GIs, and longitudinal care of a patient with benign disease with very complex surgery at times. So that seemed appealing. Then, of course, there is colon and rectal cancer. That's also the realm of colorectal surgery. And, of course, medical and surgical oncology. So you get to hang out with those guys if that is something that you choose to do more within the field. There's also all the things that you see in and out, basic bread and butter stuff like diverticulitis, and then more esoteric things like pelvic floor disorders, like constipation, fecal incontinence, rectal prolapse, all of which is becoming more and more operative. And finally, the thing that we never learned in residency, or at least I never learned it at Mass General, because nobody wants to do an anorectal case when you can do a Whipple. And that's also the realm of a colorectal surgeon. And as I said, to become a colorectal surgeon, you have to be board certified in colorectal surgery. You have to pass first your general surgery, written and oral boards, and then after you've done your fellowship in colorectal surgery, you have to take a written and an oral board in colorectal surgery, and that's what makes you a board certified colorectal surgeon. And interestingly, the board of colorectal surgery is older than the board of general surgery. Did you guys know that? It's one of the most established subspecialties out there, but it was at that point the board of proctology. And then once the general surgery was established and the the colorectal surgeon said, well, we don't really just want to do proctology. We want to do everything else. We want to train as general surgeons first. And that's how the name was changed to colorectal surgery, and that's how the scope of the practice expanded. So what do you learn? The fellowship is 1 year. It's a clinical year. There is no required research during this year. And you'd get training in colonoscopy. You get to do a lot of colon and rectal surgery and trained in minimally invasive techniques. So the picture I put up there is of one technique that I didn't even know existed until I did my fellowship, and that's transanal endoscopic microsurgery. And I'll give you a tidbit of that in a minute. But you will also learn laparoscopic colectomies and proctectomies, robotic surgery, and mostly proctectomies and rectopexies, which also require a lot of suturing. And that path to get to this fellowship, you have to go and apply at the end of your 5th year through an ARS match. And it is an ACGME fellowship, which means that there are work rule requirements and you cannot be an attending during this period of time. So it's different from some of the other fellowships that we discussed. And for those of you who don't know, this picture there, transanal endoscopic microsurgery, is the first laparoscopic procedure ever described. This procedure was described by Dr. Buse in Germany before the first lab chole, and it involves placing a proctoscope in the anus and then inserting long instruments through this instrument to do local excisions of the polyps and rectal lesions going as high up as 20 centimeters. Now, the same technique is being used for nodes. In fact, we've ran the first trial at Mass General where we removed the rectum and the colon with this technique and performed coloanal anastomosis or colorectal anastomosis on patients, and that will become soon yet another way of removing rectal cancers. Anyway, what do you have to show the board to be allowed to sit for the boards? This is the minimal requirements. You have to do lots of procedures for hemorrhoids and fistulas and fissures and pilonidals and all those things that you would not necessarily learn how to treat, even though they're everyday in and out problems that you may be facing once you are in practice. And then, of course, a lot of colectomies, both segmental and left-sided, low anteriors, abdominal perineal resections, and surgery for Crohn's and ulcerative colitis and pouches and stoma procedures and peristomal hernias. But also you will learn how to do colonoscopies, flexible sigmoidoscopies, proctoscopies. So it gives you quite an arsenal of tools and quite a spectrum of diseases that you could treat. So if you're interested in treating not just one disease, but many types of diseases, and perhaps choosing within those diseases what appeals you more, this specialty is broad in terms of scope, so it would allow you to subspecialize even within the specialty itself. And if you want to hang out with us, the best place to spot us would be at the American Society of Colorectal Surgery, ASCRS, which we lovingly call ASCRS, because we are butt-centered somewhat. And the next meeting is in Hollywood, but that's very soon, so you might not have time to set this up, but come and visit us in Boston next year, which is where the next meeting will be. That's it.
Dr. Aram Demirjian. He did his surgical oncology fellowship at the Johns Hopkins University, and he's currently an assistant professor at UC Irvine.
Thanks to the Residency Education Committee and Dr. Murayama for the opportunity to speak to you guys today. I just wanted to start with a little bit of background. In his presidential address to this Society for Surgery of the Alimentary Tract in 1992, Dr. Cameron actually spoke of the need for fellowship training in alimentary tract surgery. As you see in the table here, this was general surgery residency experience at that time, and at a time when work hours were not limited and people tended to have larger operative experiences. And you can see the list of cases here. But if you look at the more complex cases, such as esophagectomies, Whipples, liver resections, total gastrectomies, the average number among residents in the United States was actually 0. And I don't really think that that's gotten much better in the era of restricted work hours and other things. And he said that the surgeon who wishes to confine his or her practice to complicated procedures on the alimentary tract really does require further training. And as Dr. Jayaraja pointed out earlier, I think that holds true even more now. In the 1980s, there was a thought that although aggressive training and long training in complex surgical techniques and cases was important, it was also important to think of the patient as a whole and the care of their disease as a whole. So I like this quote from Dr. Pollack from MD Anderson, basically saying surgical oncology is a cognitive as well as a technical procedural specialty that is a disease-oriented rather than exclusively anatomic-oriented and defined surgical specialty. And I think this really highlights the point of thought and action. And it was recognized by the SSO that you needed to really do more in training than learn how to do technically complex cases. We all love technically complex cases and we all want to do them, but taking care of patients as a whole is more than just that. And oncology or cancer is really one of the areas where surgeons can be at the forefront. So I think really the mission of the SSO, which still holds true, even though the Surgical Oncology Fellowship is no longer run by the SSO as of this year, emphasis on the multidisciplinary care of the patient, interacting with various other disciplines that would be involved in the care of these patients, whether they be medical oncologists, palliative care physicians, radiation oncologists, nutritionists, and other things, and really learning to interact with these other groups, learn from them, and develop a certain amount of humility by working with them. So this is just my background. It was mentioned briefly, but I trained in general surgery. I took 2 years off to do basic science research. I did a fellowship in surgical oncology when it was still run by the SSO, and I was actually fortunate enough to walk into a practice that is 100% hepatobiliary and pancreas, which was what I wanted to do in the first place. So my perspective was approaching an SSO fellowship from the standpoint of wanting to be a hepatobiliary and pancreatic surgeon. Some statistics from the SSO, these are from the 2013 match, 103 applicants for 56 positions, 21 programs total. And this is looking back as far as 2004. You can see the number of spots and number of applicants have generally grown over the past 10 years. I have some data going a few years back, but I just put the 2012 match as a representation. All surgical oncology spots were filled. 27 applicants didn't match. But if you look at people who got their first or second choice or adding their third choice, up to 82% of people were able to match in one of their first 3 choices. So what goes into a successful surgical oncology application? Well, that's a hard question to answer. I spoke to a number of program directors. They all wanted to be off the record. And there are no strict guidelines in terms of what you look for, but these are some of the things I heard about. Research experience, whether it be bench work, whether it be outcomes research, and then publications. Some look for quality, some look for quantity, some look for a combination of both. Leadership qualities, is there anything on your curriculum vitae that shows that you might be a leader in the field in the future? Believe it or not, ABSITE scores was mentioned by somebody. And then where was your general surgery training background? What further do you bring to a fellowship? And then in terms of fit, what are you both looking for? General areas in surgical oncology: foregut, HPB, melanoma, soft tissue. There are many other, as fragmentation in subspecialization in general surgery kind of continues to progress. There are separate breast surgery fellowships. They've been around for a while. There are more than 30 of them now. Colorectal surgery fellowships, the numbers are growing. And traditionally, different programs that had prepared graduates for treating patients with cancer have kind of split off into various areas. And different programs in the SSO have kind of long been known for different strengths and weaknesses, mostly anecdotally. And there have been always a token number of minimum procedures that each program needed to do, but there was always a thought out there or an attitude out there that certain programs prepared you more for HPB, certain programs potentially more for melanoma and soft tissue, and otherwise, whether those be true or not. Surgical Oncology Fellowship does prepare people for academic or community practice. The study out of Memorial Sloan Kettering that looked at 68 fellows over a 10-year period They did surveys, 67 of the 68 responded, and they had excellent job satisfaction, and many of them were in full-time academic positions, but with a good balance of patient care, research, and education. It provides a broad training in multiple areas, so it does prepare you to go be a more generalized general surgeon in a potentially more remote area if there isn't as much subspecialization. But if you want to be a subspecialist, that's also certainly possible. Marketability is another thing. When you train very, very specifically in something, then when you go looking for a job, the people that want to hire you may think that that's what you specifically do. And I had some blind luck in terms of what I found, but I didn't really have the expectation of walking into a practice that was purely hepatobiliary and pancreatic surgery. So surgical oncology really prepares you in many ways to be able to be a multiple threat and do many different things and potentially make you more marketable. So just a couple of words about changes. This was traditionally run by the SSO Training Committee, but surgical oncology has now been an ACGME certified specialty. This is the first year, and it will have its own board certification exam going forward. And so while minimum case numbers had been established across surgical oncology programs, as long as those minimums were met, there was very little regulation otherwise in what programs did. Spending 2 years at Johns Hopkins, I can tell you that probably 80% or 70% of what I did was either hepatobiliary or pancreatic surgery work. And while minimums in the other areas were met, not to the point where someone would say, oh, let's hire this guy to be a breast surgeon or something along those lines. So I think there are some changes that are coming forward. There are no current minimum guidelines. I mean, there are minimum guidelines, but the ACGME, I think, is going to revise those as time goes forward. It's going to take an evaluation of the various programs to look at what programs are doing and what they should be doing and kind of go from there. So this kind of says a little bit of the same thing, but really it's the general principle of technical training combined with a broad understanding of comprehensive cancer care, which is kind of the mission and will persist. There's special thanks to a couple of people. Thanks.
So I want to thank all the panelists. It is a tour de force to get all these very experienced and accomplished people together, but I think they did a great job of giving you some perspective on what it means to be a fellow in each of the areas. We're going to have a question and answer session, but before we get to that, I want to remind all of you that the SSAT is the sponsoring organization for this panel, and while the SSAT itself doesn't sponsor a fellowship, it is really one of the premier GI surgery societies in the country, and so I don't want you to leave here thinking that all these other organizations are great. I think the SSAT is really the organization where many of us got our start in GI and general surgery, and I can allude back to my own experience as a resident where I presented at the residents and it was then a residents research conference. There weren't that many fellows then, unfortunately, but for 3 years. And really the collegiality, the friendships, and the relationships that I built in those 3 years where I presented has carried through my 22 years in academic surgery now. And I will tell you that many of the people that I see at meetings I met at those initial research conferences. So the SSAT does sponsor a research conference, and I would absolutely encourage you to submit your best work to that. It meets on Friday. It met yesterday, and it's a wonderful meeting. The science was fabulous. Dr. Vote and Dr. Michelazzi, Dr. Ashley back there are all very instrumental in putting that program together for us, and I think you will all benefit from the relationships and the friendships you make through the organization. So I wanted to make sure that I get that in, since all of the other organizations are represented here. I don't want you to think that the SSAT wasn't one of the important organizations and maybe the premier GI surgery organization in the country.